Hello, everyone. I think we'll give it like another minute or two because we have about half of the people on that have registered. So we'll give it another moment before we actually get started with the presentation. And as Amy mentioned, we are recording this session.
No, what?
Yeah.
No shit. Well, that'd be like Brandon too.
Good afternoon. This is Lynn Nibelink, and we're gonna go ahead and get started. I'll just start with introductions while people are still joining, and some people need to still make sure that they are muted as they come on. I'm Lynn Nibelink. I'm from the Iowa Department of Human Services, Division of Mental Health and Disability Services. And then also my colleague Leanne Moskowitz from Iowa Medicaid Enterprise is here today and will be answering questions as well. And I believe our colleague Tammy Emsbaugh is with us as well to assist in answering questions. We're going to go through a PowerPoint presentation that talks about individual placement and support model of supported employment and the Aspire initiative. And then we'll hopefully leave plenty of time for Q&A towards the end. So let's see if I can go ahead and share my screen. And Amy asked me to mention again that we are recording today. There are people that wanted to hear the presentation that aren't able to free up this time. And so hopefully they can watch the archive. Okay, this is about the Aspire application to provide the evidence-based practice of individual placement and support. We're going to talk through who is this announcement for, why are we interested in employment in a mental health system, what is the EBP of IPS, what is Aspire, and then some details of what do you need to know to become an early adopter or an applicant. Iowa's employment vision, many of you have seen this before. We're talking about employment in the general workforce being the first priority and the expected and preferred outcome when we're working with publicly funded services. So this is about IPS, Individual Placement and Support Model of Supported Employment. It's an opportunity for providers to, or for teams to provide IPS services in exchange for some training and technical assistance that we've secured from national subject matter experts. There will also be training and TA from Iowa-based staff and access to outcomes-based funding from Voc Rehab and Medicaid for these IPS services. This application is available for applicants in teams, which would consist of a community mental health center or IHHs or both MHDS regions, community rehab providers who are enrolled for both voc rehab supported employment and Medicaid habilitation for supported employment. And all parties need to be in good standing. In other words, not have any of the aspects of your licensure or anything in question. In addition, we are particularly seeking new IPS sites or teams that are geographically dispersed from our existing IPS pilots. And if you're not aware where the pilots are currently, we will talk about that in a little while. Also, the new sites or teams, we would like to have them have potential to serve members of diverse or underserved communities in your geographic area. And then just be aware that through the Aspire effort, we will assist you in securing subject matter experts to help you address those underserved or diverse communities that you identify. The required roles in an IPS team are the employment service specialist, who will become trained as an IPS employment specialist. You need a behavioral health specialist, you need case managers or care coordinators, your VR counselor, representative from your MHDS region, and we really would strongly encourage you to include peer support specialists or family peer advocates on your steering committee and on your team. So why should a mental health system focus on employment? One thing is, we know that work is the most normalizing goal that we can help people to achieve. Instead of asking if people can work, we need to ask people how we can help them get to work. Employment is a central clinical concern. Work is a way to approach other treatment goals. It's an essential part of recovery. It helps people to identify with a normal role in society instead of just being a patient or a consumer. Okay, everybody knows how unemployment affects a person's self-esteem, self-regard, basically exacerbates mental illness symptoms. And conversely, employment helps us with our quality of life, reduces instances of substance use, reduces mental health symptoms, hospitalizations, costs, all of that. So I think that's pretty common knowledge. We're not going to elaborate on that. For most people, employment is a part of recovery. 70% of the people with a serious mental illness want to work, but in fact, only 15% of those people are employed. Work is the best treatment that we can find for serious mental illness. And that has been shown through numerous research studies. Only 2% of clients or persons with serious mental illness in the US public mental health system actually receive IPS. So we haven't penetrated the system very deeply with this model of supported employment yet. What is IPS? IPS supported employment helps people with serious mental illness or behavioral health conditions to work at regular jobs of their choosing. There are variations of supported employment, and IPS refers to the evidence-based practice of supported employment. It was invented or created quite a few years ago by Bob Drake, who is a psychiatrist, and Debbie Becker, who is a certified employment specialist provider. It's research-based. There's a lot of randomized control trial research that shows how effective it is. There are standardized practice guidelines, which are well-defined, and it's a manualized service approach. In other words, there's a 25-point fidelity scale, and it's very clear when you have met various points on that fidelity scale, how much you're actually doing IPS versus something else. This is a quote that's actually a couple of years old, and so like the term consumers, we don't really use that anymore, but I like the quote where it says, an evidence-based practice is a clinical intervention which has been consistently shown in several research studies to assist consumers in achieving their desired goals of health and wellness. And I took that from Debbie Holman, who is currently one of the Wisconsin's IPS trainers. She was previously an Illinois IPS trainer. Here's some quotes from people that have been involved in IPS. One person says, when you're working, you're part of the real world. You feel connected. Having a job gives me stability. I have something to look forward to every day. A parent says, I worried that if my daughter got a job, she would feel stressed, but just the opposite happened. She's doing much better than before. And then an employer says, the employment counselor helped me to understand why Tony paces, and it's okay in the security business. So he's saying it's, you know, the guy paces, but that's okay when you're a security guard. You'll hear IPS talked about as having a three-legged stool. So there's three critical elements that it stands on. You have the funders of IVRS or Medicaid and MCOs. You have the community employment provider, and you have your mental health treatment team. And these are like the critical pillars that help people provide the best opportunity to get the jobs. Here is a snapshot of the 8 practice principles. Again, there's a lot more information available for these. I'll give some research or some resource citations towards the end, and you can look these up. Some of the critical differences from regular supported employment is IPS is a rapid engagement model, and we also don't exclude people based on like symptomology or if they're still using substances. If people present and say they want to go to work, then we begin working with them and we get them engaged in getting employment as quickly as possible. There are 28 randomized control trials that show an average of 56% of IPS participants got competitive jobs. And that's compared to about 23% for our standard supported employment models. 2/3 of these studies had at least an 18-month follow-up. People served in IPS get employed faster, they hold their jobs longer, and they typically work for more hours. The long-term randomized control trials for IPS showed that they were 3 times more likely to get work and worked 4 times as many hours as standard supported employment. In 2012, there was a University of Iowa study of the MEPD population. This wasn't specific to IPS, but it is specific to working, as the MEPD population is those who are working, showed that the Medicaid claims of people working as little as 2 hours per week, they had 21% less health expenditures or less Medicaid expenditures in a month versus those people who were not working. And they were matched for all other kinds of characteristics. Bob Drake says, nothing that I have studied has the same kind of impact on people that employment does. Medication, case management, and psychotherapies tend to produce a small impact on people's overall adjustment, but the differences are often striking and dramatic with employment. So back in 2018, here's where we talk about the pilots a little bit. There were 2 employment providers who stood up with 3 MHDS regions, and I think there were 4 community mental health centers and IHHs involved that stood up 3 IPS teams at that point in time. They're now, I believe, 5 in those pilots. But they did that they contracted with a neighboring state's IPS trainer and fidelity reviewer who came into Iowa and trained their teams and got them through the startup phases up and running. And then they provided the IPS services and got their baseline fidelity reviews back in, I believe, 2019, I'm pretty sure the fall of 2019, they did their baseline fidelity reviews. And they actually showed their success rates were 64% and 75% success rate at people becoming employed through the IPS pilots versus, you know, the typical 23%, and even actually better than the nationwide average of 55% success for the IPS programs. So another striking thing about these pilots was that on their baseline reviews, fidelity has 4 levels. The bottom level is basically you're not doing IPS, so it's you've failed at doing IPS. The next level is you have fair fidelity to the model, and then towards the top you have good fidelity to the model, and way at the very, very top there is exemplary fidelity. It's a scale that goes from 0 to 125. And our pilots on their baseline fidelity reviews both achieved a good fidelity, which is very uncommon for new IPS providers. This is a success story from one of them that I really like to share. A young lady, one of our pilots served a young lady who was 19 years old at that time. From the age of 17 to 19, she had been hospitalized more than 30 times for her mental illness. Then the pilots got started and she got involved. And once she got a job through IPS, she didn't have any more hospitalizations. Then 2020 hit and COVID became a reality in everybody's lives. She lost her job due to COVID. She was unemployed March, April, and May of 2020. And during that time, she experienced 3 more hospitalizations. Then the IPS team helped her get employed once again. And she has, to this day, remained employed in that job and remained stable in both her employment and her mental health. So I think that's quite remarkable. Now let's talk about what is ASPIRE. It stands for Advancing State Policy Integration for Recovery and Employment. It's an initiative out of the U.S. Department of Labor, the Office of Disability Employment Policy. The federal goal is to promote competitive and integrated employment through the evidence-based practice of IPS. You can see here there were 7 states awarded, and what we are awarded is 270 hours of technical assistance from the nation's experts in IPS. We call them subject matter experts, or SMEs. We started in March of 2021, and this initiative goes through August of 2022. There have been some hints that it'll probably be renewed for, you know, a year or 2 or 3 or 4 afterwards, but at this point we're gearing all our activities for this initial time period. Iowa's goals with ASPIRE are, number 1, we need to build up our infrastructure for IPS. So we wanted to develop and sustainably fund 1 to 2 full-time positions for an Iowa IPS trainer and fidelity reviewer. That's been one of our barriers in the past, that we were not able to have our own trainer and reviewer. And there are costs, of course, associated with that have prevented other places around the state from standing up IPS teams. Our second goal is capacity. We want to use this initiative to implement or stand up to 3 new IPS teams this year. And that's what this announcement is about, is to solicit for those teams. And then our third goal is regarding diversity, equity, and inclusion. We want to increase attention to responsiveness in access to and delivery of IPS services to traditionally underserved and diverse populations. And that includes racial and ethnic and religious minorities, LGBTQ, And also we've included justice involved and what we call extreme rural or farming culture communities. There's actually a national designation of areas that are considered extreme rural, and they coincide with your health professional shortage areas typically. There's about 23 counties in Iowa, I believe, that fit that national designation. Our target populations with Aspire and IPS in our 3 teams that we're looking for, we want you to serve adults and transition-aged youth with serious mental illness. Mental illness can be a secondary diagnosis, could also be multi-occurring mental illness and substance use disorders or complex needs. Ideally, persons need to be eligible for voc rehab and Medicaid since it's a braided funding model. And of course, we want to include that outreach to our diverse communities. So let's talk a little bit about your application. This was all included in the letter, but we want you to include just a brief cover letter stating, who you are and so forth. A written proposal that summarizes your plan to provide IPS, not more than 5 pages. There's a questionnaire that was included as an attachment, attachment A. There's a brief budget summary, which is just a very brief sketch or overview. And then your respondent information asks for like some legal information things. Please include letters of support with written assurances from your required team partners. That shows us that you have actually been having conversations together and starting to form a team and build a team. This all needs to be submitted to myself. There's my email address. And the deadline is 4:30 p.m. Central, July 30th. And put this heading in your subject line if you could, please, to help sort those emails from others. So here's the important dates on the application. July 30th, the proposals are due. We'll make our selections of the top 3 by August 20th or on August 20th. Hopefully by September 3rd, we'll have letters of agreement completed with these entities or teams. It's not a contractual thing. It's just going to be more, it's not necessarily informal, but it's not as formal as like a contract. But there are certain assurances that we need to have made in order to commit these resources to these teams. Then we're hoping by September 17 that you'll have your IPS introduction trainings. And by October 1st, you'll have held your strategic planning meetings. And then through October and November will be your kickoff and your major IPS trainings and program startup that would involve our national subject matter expert and our newly hired and being mentored and trained Iowa IPS trainer and fidelity reviewer. Here are some other resources that I mentioned. The habilitation rules are in the process of undergoing revision right now to include the IPS program. And then the IPSworks.org is the employment center at Westat, and these are our international experts and our subject matter experts for Aspire. IPS fidelity requirements is shown in that bottom link, and that will give you a snapshot of what is best practice as far as operating an IPS program. Now I'm going to just go quickly through some slides from the IPS Employment Center about starting up IPS teams. So who provides the services? We have IPS specialists, or you will have an IPS specialist who are employment service specialists that get trained in providing IPS. They work closely with your team of practitioners, and you all work with the same clients. IPS is integrated within the team. This is probably one of the biggest tenets of IPS is it is a team effort. You guys meet together. How our pilots have done it in Northwest Iowa is they tried, the employment providers tried to fit into the mental health treatment team's schedule of meetings, and that has worked okay for them. In Central Iowa, it was a little more difficult because they are working with, the Central Iowa pilot is working with 3 different mental health treatment teams, not just like one mental health center. So it's some juggling. You need to develop a steering committee that will build the consensus for your program and to oversee the implementation. And you want representatives from your critical stakeholder groups on your steering committee. Everybody, you know, these people all need to have buy-in and be able to help educate your stakeholders about IPS in order for it to become successful. To maximize your funding, you know, there's quite a few different pieces that go into funding an IPS program, and typically funding has been the biggest barrier in every state for standing up IPS teams. There used to be large and long-term private foundation grants, particularly from Johnson & Johnson, that would give states millions of dollars over 5 years' time. And that's how a lot of states got started. Those things have typically dried up over the last 5 or 10 years or so. So that is not available anymore. This was why Aspire is so important to us. So you're looking at which funding sources pay for which parts of IPS, looking at funding from Medicaid and VR, state, the Community Mental Health Center block grants. And it takes about $5,000 per person for the service pieces itself. Now, the good news is that our team basically we have a steering committee and an employment first team that's been working on IPS for a couple of years. We've done a lot of this work for you. As you can see in the announcement, Voc Rehab and Medicaid Habilitation have braided funding and created a model to pay for that services aspect of the person, and it's in excess of $5,000 per person if the person meets all those outcomes. Other pieces are the cost to the Community Mental Health Center, and we've recently learned that CMHBG funds can be used to support the Community Mental Health Center's work on an IPS team. The training and technical assistance that it takes to stand up your team and get started will be funded for these 3 teams through the Aspire initiative. So you don't have to worry about finding money to pay consultants to do that. And then your baseline fidelity reviews will be covered by the Aspire experts as well. So what that leaves you with is there is some seed funding that is typically very helpful to organizations in order to get off the ground, to support your staff and your work until your caseloads get full and the outcomes funding starts to roll in. So that's really what is left to see if you can work with your MHDS regions or other entities or sources in order to help you fill those gaps. The organizational structure as far as IPS, you have the specialists who join 1 or 2 treatment teams. It's great when they can share office space and attend the weekly treatment team meetings to discuss your shared clients. You have your mental health treatment team that integrates the IPS and the benefits counseling, the care management, medication management, substance abuse, all of those things into the team and its work. And then you have an IPS supervisor who provides your weekly group outcomes-based supervision to your IPS specialist or specialists. You'll have ongoing TA And this will be provided again by our Aspire subject matter experts and the newly trained Iowa person. And then you'll be tracking your outcomes and your progress. There's a little standardized sheet. I think there's an example of this in the announcement. Fidelity, like we said, it's scored on a 25 item scale. Each item is scored from 1 to 5, maximum of 125 points, which would be exemplary fidelity. And then your baseline fidelity review is made by independent assessors during a 2-day site visit after you've been in operation for 6 months or more. And that is it for the PowerPoint presentation. And there you have my contact information. And I think we are ready to go to question. And I think, Amy, are you going to assist if there's questions in the chat?
Sure.
Or do you want people to raise their hands, or how do we want to do this?
I would suggest that people could go ahead and either just unmute themselves and ask a question. They can probably turn their cameras on now if they choose to, or they can type it in the chat box and I can alert you.
Very good. Thank you. Don't be shy, and if you're asking a question, don't forget to unmute yourself.
I'll start. This is Maria.
Hi, Maria.
Hi, Lynn. Hey, I have a question in general in terms of, are there priority areas that you're looking for in terms of developing IPS throughout the state, in terms of urban versus rural?
We're not excluding urban or rural. Really the only thing we said is we want them to be not in the geographical area where the pilots are. And we want you to be able to identify what underserved or diverse communities exist in your geographic service area that you would be designing some outreach for. That is, it's really a federal priority. To see that best practices are made more available to underserved populations, or typically, not mainstream populations in one respect or another.
Okay, so it's the equity component of it.
Yeah.
Okay, thank you. Okay, I have another question if no one else is going to ask. So the $5,000 rate that was established per person, what is that based on?
Leanne can probably answer this a little bit better, or Vienna. I'm not sure if Vienna is on today or not. But there's like, I think 4 outcomes that people go through and achieve as they go through IPS. Mm-hmm. And they took the habilitation rates for certain services and so many units and broke those down according to what would be payable at certain outcome levels. And the thing with IPS is you get paid in one lump sum when you achieve that outcome. So it's more helpful to you than having nickels and dimes as you document hours of service. Leanne, do you have anything that you can describe that better?
The average cost of $5,000 per person? Is that the question? So yes. The $5,000 per person, I believe, was based on the pilots that were operated by 43 North Iowa and Hope Haven, Rock Valley. when they were working with their regions to, you know, set off those services. And so, you know, they kind of projected out based on their costs and their experience with the pilots, what the average cost was per member to deliver the service. And then of course, the reimbursement methodology that we implemented under an exception to policy for those two providers is reflective of those costs related to, you know, achieving those 4 outcomes for members. And so, yeah, that's the average cost. The rates, so the outcome payments for the 4, or the payments for the 4 outcomes will, they're in part of the IPS administrative rules. Those administrative rules, public comment has closed now. I believe we're targeting a September 1st implementation date of those rules based on going back to the Administrative Rules Committee, you know, one more final public, you know, publishing of the rules and all of that. And so the method, the reimbursement levels will go up a little bit based on the appropriations in House File 891, but it'll be based on the same, you know, level of payment, and we'll be doing away with those, you know, them billing the traditional SE codes for those services to billing IPS specific codes for those services once the once the rules are adopted and implemented. So that's kind of where things are at right now as far as the rules go. And so there'll be a separate outcome payment for each of those tiers. It'll be billed at the T2018 with U3, U4, U5, or U7 modifier, I believe. I'll have to go back and check my notes. So it'll look similar or the same as it does today under the exceptions to policy, with a little bit bump in reimbursement and specific modifiers, and using that T10 or T2018 for all 4 of those payments. So maybe that gives folks a little bit of more context as to where we're at with the adoption.
Hi, this is Rachel with the Cross region. I had talked to a region that had a program, and they said they did a guaranteed payment of $5,000 and change a month. And so is that in addition, was that region doing that in addition to other funds their provider was receiving?
That was one of the pilots, and their what happened with the pilots was the state did not support them financially at all because we didn't have any means of doing so at the time. So their MHDS regions, there was Sioux Rivers, Northwest Iowa Care Connections at that time is what it was called, and CICS. And I believe it was CICS that did about $5,000 per month to 43 North Iowa. And that was, at that point in time, the employment provider did not bill Medicaid or voc rehab hardly at all for any of their services that they were doing. So when we costed that out, that $5,000 per month, that came into an average. It factored into our average of what we call the seed funding. That's helpful. Not going to say necessary, because I know places that have done it without seed funding, but helpful to stand up a team. And so what, in place of that, you know, we have figured out how to get you your training and your TA at no cost to you through Aspire. And also VR and Medicaid have figured out the services funding through the outcome model. And that $5,000 per person for the actual services, that's actually a national average as well as what our pilots averaged out to.
Okay, so those are two different 5,000s.
Yes,
okay,
that's correct.
That's where I was getting confused. Okay.
Yeah.
Thank you.
Lynn, we have a couple of questions. One is, In order to submit a written proposal, does an employment service provider need to collaborate with the local mental health center and the MHDS region to write the proposal together? In other words, have a team created prior to submission?
Yes.
So would it?
Yes, you need to have your team needs to be in formation and do a one joint proposal. When you need to be able to, by the time you submit your application, you need to be able to show that you have a team of those people who all agree you're going to work together on this effort.
Can you highlight again, Lynn, the required team members, the representation?
Yeah, let me find that slide back a minute, sorry. While I'm looking for that, I will just mention in the chat, somebody asked about what is considered extreme rural. There's actually a federal designation. I can't remember what the words are for it, but where they look at zip code areas and extreme rurality. And there are 23 counties in Iowa that are, the whole county is considered extreme rural. And then there's another 28, I think, that are have little pieces of the county that are considered that federally designated extreme rural. I don't have a list of exactly which counties those are yet, so I can make work of trying to find that out, if that would be helpful to you. I will say, typically, you know if you're in a health professional shortage area, and typically those extreme rural counties are that, and you also know if your counties are typically more impoverished than the average area of Iowa.
While you're looking for that, Lynn, I just want to...
I can't find it. What in the world did I do with that? All right, let me try again. Go ahead.
I just want to share a comment that Vienna had put in the chat. Vienna's with IVRS. She said it's actually $5,991.28 to be exact. So it's closer to $6,000 than $5,000 for reimbursement. And then there was another question related to, would there be extra points in the application awarded if there is seed money secured?
I wouldn't call it extra points, but it's a higher score. Yes, you will be, the applications will be scored on to what extent do certain things play into your potential future success. So yeah, if there's some seed money, you probably get a score of 3 on a particular question, versus if there's a whole lot of seed money, that application might get a score of 5, versus 0 seed money, that application would get a score of, I don't know if it's 0 or 1, I don't remember. The required roles, I found that. It's on slide 7 if you download the PowerPoint. An employment service specialist who will be trained as an IPS employment specialist, a behavioral health specialist, case manager or care coordinator, VR counselor, representative from your MHDS region, and then you are strongly encouraged to include peer support specialists or family peer advocates on your team if possible, and certainly at least on your steering committee.
Thank you, Lynn. We have another question. Is it acceptable to subcontract with other organizations to fill some of the roles rather than hire brand new employees to fill spots on the team?
My answer would be yes. I don't know that subcontract maybe is the right word, but Aaron, I'm not familiar with what type of agency you're from or what type of role you're at, but you just have to have all those people represented on your team. You don't need to employ them all.
This is Erin. I just wondered the relationship. I mean, like we have Iowa Workforce, we have other people that already have staff that does some of those roles, and we're a community mental health center. So if there was capacity that we could kind of build that team with people who are specialized in that already.
I would say yes. And I think just be very clear in how you describe those relationships and those roles when you write your application. Like, for example, let's say up in Northwest Iowa, the pilot team that includes Hope Haven Incorporated up there. Hope Haven Inc. is the employment service provider. They have 2 IPS employment specialists and 1 IPS employment supervisor. And then they are teamed up with Plains Area Mental Health, who has the integrated health home teams. And they also team up with, in other counties, they have, I don't recall what's exactly the right term, but independent mental health providers. They're not CMHCs, but they're independent mental health providers. And then they have a couple of VR counselors serving their counties that they work with on their teams. 43 North Iowa actually almost has like 3 separate teams because they have 3 different VR counselors in their coverage areas and 3 different community mental health centers. Even though I think the agency 43 North Iowa employs, I believe, 1 IPS employment specialist and 1 IPS employment supervisor. So I don't know if that's helpful description to you.
Yes, thank you. Could I add a comment, Lynn? I just wanted to say that as you're looking at potential subcontractors, it might be really critical that they actually really specialize. Like, for example, if you're the mental health provider, you might really want to find someone who specializes in supported employment, which might be, not that you were inferring this, but more focused than, for example, like a workforce center staff. So it depends, but I know that you could subcontract with those other agencies that are experts in the areas that need to be represented.
That makes sense. Thank you.
I don't see any other questions at this point, Lynn. Does anybody else have anything else they'd like to ask, either in the chat or by unmuting yourself?
Well, we're waiting to see if people do. I just want to thank Vienna for putting that in the chat about the actual dollars, very close to 6,000 versus 5,000. And this is something that I've always been proud of Iowa. You know, that Vienna and Leanne were able to piece together that model early on in 2020 to be able to support the IPS services. I think we're in good shape that way compared to nationwide.
I had one question. This is Sandy Anderson with Goodwill in Iowa City. So this will be something that you do each year. So if you didn't have your team arranged and ready to go for this proposal, there would most likely be another opportunity in a year. Is that correct?
That is what we are hoping. We really are hoping that this is our kickoff year and that we can get an Iowa IPS trainer and fidelity reviewer on board to be trained by that National Center of Excellence and then and mentored by them. And then next year, what we've learned from the national folks is that one state IPS trainer can basically stand up or implement 3 new teams per year. Okay. And so that's kind of the model that we're hoping to continue on, is that Iowa will just carry on adding 3 new teams per year until we have the whole state covered.
Thank you. We had did a previous project with IPS, but it was with the DD population, and then of course COVID hit. So I have quite a bit of background with the IPS, but I did think the partnerships were an area that we didn't get down to a fine science, and that taking the time to really develop those relationships and partnerships prior to trying to kick it off would be pretty important.
That's a really great point, Sandy, because yeah, we're aware of what you guys have done, and I think it's great that you were able to do the pilot that you did. I think it's a good point that, you know, partnerships take time, teams take time to build. That is also part of why we've been sticklers in this application of requiring that team members are already accredited and already ready to provide those services that are required, is because you have enough to do with building your teams and getting your steering committees and your strategic planning done without, you know, starting from the ground level of a service provider that is just getting into doing it. So I think that's a great point for you to have brought up. And yeah, it's, you know, there's going to be some that are ready to hit the ground with this year's application, and others like yourselves that even though you have some background in doing IPS, you want to take more time to carefully develop your team and those relationships. So yeah.
Thank you.
Lynn, I had a question. If individuals wanted, you know, as they're putting their ideas and their proposals together, if they wanted some, if they have questions or want more information, what kind of options do they have to learn more from the folks who've been engaged in this longer so they can put a solid proposal together? What kind of folks are, what kind of resources can be accessed to help with that?
To help do, I'm sorry, what? I was trying to multitask and my brain has failed me.
No problem. What kind of resources are folks on the Aspire leadership team or advisory group or the providers or yourself, for example, available to answer questions as individuals across the state might want to put together strong applications? They may have questions about some of this that they haven't been exposed as much as some of the rest of us who've been working on things. Mm-hmm. So can they reach out to just ask questions and gather some information? And would that be you, Lynn? That would be a good starting point, or what would you recommend for folks if they wanted to you know, get some more information as far
as absolutely. I think if you have questions and you're not thinking of them today, you've got my email. Go ahead and reach out. And if I guess I'm not going to say you can't talk to your local people. If you're aware of who's on the steering committee for you know, for Aspire, I think that's fine. I would ask that you don't ask other people at the state level, because I mean, this is not an RFP, but it's sort of a not totally informal process, and so we're trying to funnel Q&A through myself. So I would say go ahead and, you know, you can email is really the best, because we're still working remotely, and so if you call my office phone, I don't oftentimes get those phone messages until a day or two or so later on. So yeah, please feel free to ask the questions that you have as they come up.
Fiona also clarified that, or wanted to share that coming up in July 1st, which is right around the corner, that because IVRS is increasing their fees for service, that the IPS total payment will actually be $6,305.84 per person.
Yay! Tyler asked a question in the chat. I don't know if everybody can see it or not, but he said basically if turnover happens and they lose their IPS employment specialist, are they able to rehire and train somebody new, or would that just stop you in your tracks? And I would say absolutely, by all means, rehire, and we will work with you to get them retrained. And turnover does happen. 43 North Iowa, well, both of the pilots experienced substantial turnover in their first 6 months, basically, but they were able to overcome that and clearly became very successful.
Lynn, could I ask, with the pilots, both Hope Haven, Rock Valley, and 43 North Iowa, they have a lot of good information from their experience in implementing this. And I know that they had shared that, finding the right person for that particular job was really critical, and that they both were kind of hung up in some lag time with maybe hiring somebody that wasn't really the best match for that position and then having it change. So it might really behoove folks to consider reaching out to Hope Haven, Rock Valley, or 43 North Iowa to just, if you would like to get some input from them about things that they've learned or things they might recommend as you're strategizing, pulling your team together, they could be really helpful.
I agree with that. I don't have their emails and their phone numbers offhand, but I'm going to put in the chat who the contact people are in both of those agencies.
And I can try to capture the emails as well and put them in the chat.
And they're both, as you can understand, very busy people, but I think they were open to your questions and doing the best to answer them as they're able to, because they're very excited about seeing IPS grow in Iowa.
I would just like to add that if folks are interested kind of in digging into, Medicaid's implementation of the IPS rules, those were published in the Administrative Rules Bulletin on May 19th of 2021. And so if you're part of the IC Coalition, IME provided an update to the coalition with a direct link to that administrative rule bulletin during the coalition meeting on May 20th. So if there's a direct link to that bulletin, if you want to see the rules and see, what the implications are for implementation of IPS under Medicaid.
Thank you, Leanne.
Yep.
And Amy, thank you for having those emails handy that she's put in the chat now. We got 2 or 3 minutes left, so any last minute comments or questions? All right, I will just say thank you all for coming and listening to this today, and for coming with your questions and your interest. I hope that a number of you are going to go ahead and talk with your local folks and try and get some teams established and applications made. We're looking forward to seeing those at the end of next month. Thank you, everybody. Have a good afternoon.
Thank you.
Thank you, Lynn. Oh, yeah.